as our next presenter.
Good morning, everyone. I'm Ashley Foreman. I'm one of the fourth-year residents at Memorial Health University Medical Center, so I'm excited to be here this morning and share my research project with y'all. Oh, gotcha. Okay. Sorry, some technical difficulties. I want to thank Dr. Stephanie Tootle and Dr. Anthony Royak for helping me with this project. My research is entitled Intracervical Foley Balloon Use in Pre-Labor Rupture of Membranes and the Rates of Maternal and Neonatal Infections. I have no financial disclosures. So my objective of this study was to investigate the safety of intracervical Foley balloons for cervical ripening in patients with pre-labor rupture of membranes and relate this to maternal and neonatal infections. So a little bit of background. So inserting a Foley balloon through the vagina provides a potential pathway for ascending bacteria from the lower genital tract to the sterile amniotic cavity. We know that there's an increasing risk of intrauterine infection with prolonged rupture of membranes, and ACOG does recommend delivery at 34 weeks and 0 days or greater for this reason. Previous studies that have looked at patients with PROM that have been undergoing induction of labor with Foley balloons has demonstrated mixed results, with some showing statistically significant rates of choreo and endometritis and others showing no difference. This is important because maternal morbidity from choreo includes dysfunctional labor leading to potential increased rates of C-sections, postpartum hemorrhage, endometritis, sepsis, and acute respiratory distress syndrome. And it's also important because we know that increasing maternal intraamniotic infections during labor increases the risk for subsequent neonatal infection. So some of the risk factors that we know increase maternal and neonatal infections during labor are nulliparity, preterm gestational age, prolonged rupture of membranes, and then intrauterine pressure catheter use during labor. So my hypothesis was if the risk for maternal and neonatal infections is increased by creating this pathway for ascending bacterial infections from the vagina to the sterile amniotic cavity, then Foley balloon usage during labor would increase rates of maternal and neonatal infections. So my methods for this study, it was a retrospective cohort study, and I collected data via chart review and EPIC from November 2019 through April 2021 at Memorial Health University Medical Center. My inclusion criteria was essentially all pregnant women that came in with pre-labor rupture of membranes who were undergoing induction of labor, whether it be with a Foley balloon or some other method. And my primary outcomes were looking at rates of maternal infections, so choreo and endometritis, as well as neonatal infections, such as neonatal sepsis. And then my secondary outcomes looked at parity, time from rupture of membranes until ultimate delivery, APGAR scores, and NICU admission rate, as well as postpartum hemorrhage. So I won't go into too much detail, but Dr. Eric Shaw played a tremendous role in helping me to analyze my data. Based on if it was looking at the primary outcome or the secondary outcomes, we used various statistical tests as well as a logistic regression later on to kind of further explore the relationship between the secondary outcome variables and rates of infection. So my results for primary outcomes, so maternal and neonatal infections, I looked at a total of 379 women ages 19 to 46 that were admitted to Memorial during that time frame with pre-labor rupture of membranes. They were about half term, half preterm gestational age. There's a mishap with the number there because one patient didn't have, we didn't have any records for her neonate's gestational age at the time of birth because it was from an outside hospital. 57 patients were induced with a Foley balloon and 322 in this study were induced with some other method, so cytotec or PIT or a combination of the two. And then these are my results below. You can see in the Foley balloon group, both the rates of chorioamnionitis and endometritis were significantly increased with the p-values highlighted there. There were no cases of neonatal sepsis in the Foley balloon group. and there were 2 in the group that had no Foley balloon for their induction method. And this is just basically those results in graph form. So the patients that were induced with Foley balloon, you can see that their rates of infection for chorea were approaching around 20%, and for endometritis was approaching around 15%. How do you go back? Okay. And then these are my secondary outcomes. So looking at postpartum hemorrhage, prolonged rupture of membranes, parity, APGAR scores, and NICU admission rate. So there were essentially no significant differences that were clinically meaningful. You can see that the parity, obviously patients that are lower parity are going to have more of a chance of getting a Foley balloon because their cervix isn't as ripe when they're admitted for induction. And then APGAR scores, there was a statistically significant increase in the 5-minute APGAR scores for Foley balloon use. I'm not sure what that really means. And then NICU admission rate, there was an increase in rate of admission for those patients in the group that did not have a Foley balloon. Oh my gosh. Get back, there we go. Okay, so, and then at the end, I looked at the p-values for the primary outcomes in patients with ruptured membranes and that had a Foley versus no Foley balloon, and then we ran a logistic regression to look and control for those other variables that we know increase the risk for infection, such as preterm gestational age, parity, and prolonged rupture of membranes. And once we ran this data, we found that the rates of chorioamnionitis no longer were statistically significant. However, endometritis remained significant with a p-value of 0.041. Okay, so in conclusion, we saw that there were statistically significant increase in both chorioamnionitis and endometritis in patients with pre-labor rupture of membranes that were induced with a Foley balloon. However, as I mentioned on the previous slide, when controlling for the other variables that we know increase the risk for infection, chorio was no longer significant, while rates of endometritis remained the same, or remained increased. We talked about how there were no cases of neonatal sepsis in the patients with the Foley balloon, and I mentioned the other bullet as well. This button does not like me. Okay. So it just kind of looking at reasons why this endometritis rate remains significant despite controlling for these other variables that we know causes an increased risk for infection. I was thinking that potentially there could have been inadequate preoperative antibiotics prior to C-section for those patients that were undergoing induction of labor with a Foley balloon and then ultimately were delivered via C-section for whatever, dysfunctional labor or whatever reason. Also, GBS positive status, that was not looked at during this study. Some of my limitations were that this was a small sample size just at Memorial Health. I was unable to obtain data regarding IUPC usage during labor just because of the lack of standardization with documentation and trying to find ICD-10 codes or procedure codes during chart review. And then I did have Dr. Shaw run a subsequent chi-square analysis to try and further explore that relationship between why endometritis remained significantly increased. And there was a statistically significant increase in rates of endometritis in patients with a Foley balloon who ultimately were being induced with Foley and then ultimately underwent a C-section. So future research is needed to further investigate why this risk for endometritis remained increased in terms of looking at preoperative antibiotics and also their GBS positive status of the mom. And those are my resources.
Thank you, Dr. Foreman. We now open the floor for questions for the doctor.
Hi, I have a couple of quick questions.
Yeah.
Did you look at comorbidities like diabetes and obesity in the two groups, since those could play a role?
Yeah, absolutely.
Okay. And then what was the length of time that the Foley balloon was in?
That's also something interesting to look at too. I did not look at that.
Okay.
So if I'm an outside observer convince me that this is a retrospective cohort instead of a case control. How would you explain that to a third-year medical student? And I agree, it is a retrospective cohort. But
I looked at a cohort of women retrospectively from a period of 1 year, and just reviewed my primary outcome in terms of, didn't know I was going to get pimped on this, y'all. But it's not a case control because I was looking at a cohort of patients, and then, yeah.
Very good. Any other questions from the floor? One last question.
Sorry. Whitney Langford. It was a great talk. Super excited because we talk about this every shift. Me and the residents going back and forth about putting in a Foley or not. But I think it's very interesting that you did it at your center, but points that I wanted to see if you looked at was time to delivery. You know, those who didn't get a Foley, what was their primary end? Did they end with vaginal delivery versus C-section, things like that? And had you looked at any other studies to compare to this one? And did you find that the results were similar to yours, or were they different?
Yeah, so there were, to start with the last question, there were a lot of other studies that I looked into, and there were mixed results. Some showed increased risk for choroidal endometritis with Foley balloon, and others showed no significant difference. So that's why I was really trying to hone in on more of the secondary outcomes that we know are risk factors for infection, just to see if that was what was causing the increased risk for infection, or if it was the actual Foley balloon alone. Sorry, the other questions? There were a lot of them.
No. That was fine.
Okay.
Thank you very much,
thank you.
Dr. Foreman.